Hello, I'm B.Tomlinson. I'm based at Macau University of Science and Technology. I've been speaking about lipoprotein a. Lipoprotein a is a particle. It's a type of LDL, low-density lipoprotein particle, but it's different because it carries an additional protein, the apo-a protein. And this seems to make it particularly atherogenic. The apo-A protein is similar structurally to plasminogen, and it's postulated that it may interfere with the clotting system, so it may prevent the effect of plasminogen in reducing blood clots within the circulation. But the lipoprotein a particle is atherogenic in other respects. It seems to get into the subendothelial space more often than LDL particles. So it's well established nowadays that it is an independent risk factor for coronary heart disease. And it's also a major risk factor for aortic stenosis. So it's really well established from all the data, from genetic studies, from Mendelian randomization studies and observational studies, that lipoprotein a is a major risk factor. The levels in the circulation are very much determined by genetics. People have a gene for the a protein which varies in terms of the size of the a protein. It carries a number of repeats of the Kringle 4 type 2 part of the a protein. And people who have the larger a protein tend to have smaller levels of lipoprotein a in the circulation. Different ethnic groups have different levels of lipoprotein a. And here in India, people have rather higher levels of lipoprotein a. So it does seem to contribute quite significantly to coronary heart disease, and particularly so in India. So it's regarded as an important thing that needs to be measured nowadays. And there are ongoing studies here in India where it is being measured in patients who had acute coronary syndrome. But perhaps it would be useful to measure it before the event. And in fact, quite a high number of people in the population have levels which are above what are considered satisfactory. There's a cutoff level of 30 milligrams per deciliter, or sometimes regarded as 50 milligrams per deciliter, which is regarded as an increased risk. So it will be useful to measure it in everyone in the population to know what their risk is in relation to this lipoprotein. And it is regarded actually as the most common genetic factor influencing lipoproteins. At the moment, there's no very specific treatment to reduce lipoprotein a. The treatments that we have are really not very effective. Statins, which are the first-line treatment for lipid problems, don't improve lipoprotein a. In fact, in some people, they increase it. Niacin can decrease it quite moderately, but niacin is not readily available nowadays. The PCSK9 inhibitors, the monoclonal antibodies, alirocumab and evolocumab, they do reduce lipoprotein a by about 30%, but they are not all that widely used and, of course, very expensive. There are other treatments which are in development. There are treatments based on RNA, an antisense oligonucleotide or a small interfering RNA, and there is one oral form of treatment that can reduce lipoprotein a. So these treatments will become available, we think, probably within the next few years, and this will offer a treatment that will be important for some people who have extremely high levels of lipoprotein a. At the moment, the only effective treatment is what's called apheresis, where you have to remove the lipids from the circulation in a process a bit like hemodialysis, lipoprotein apheresis. And that, again, is not widely available and is a very expensive treatment. So it's an important thing to measure, to understand, to know about, although at the moment we don't have very effective treatment for it. But in the future, I think we will. So thank you for your attention.